Thank you, guys. I'll go ahead and use this microphone. I just so the folks in the back, particularly my dad, can hear me. So I want to thank Audrey and Food City for having me come out tonight. This is a special opportunity to talk specifically about GI and health, and I want to keep it really informal. If you guys have any questions, I want to save a lot of time at the end to go over any questions that you might have. I have a few topics that I'll be addressing tonight, but certainly these 4 topics I'll go into a little bit of depth on, but certainly we don't have to limit our discussion to this. We can talk about whatever's on your mind in regards to GI health tonight. So we'll start with, so the 4 things I'm gonna speak a little bit about. The first 3 topics are specific gastroenterology diseases that those of us in the GI field see and treat on a day-to-day basis, essentially. And they affect, I chose these 3 because they're fairly common, particularly the second one and the third one as well. And then the 4th topic, benefits of a plant-based diet, is really just more of a hobby of mine personally, and really has, in my opinion, far-reaching effects for us, particularly in the United States, with the epidemic of diabetes, the epidemic of obesity, and the epidemic of coronary artery disease, heart disease, in our country and in the Western culture. So with that said, we'll go ahead and get started. Does anyone have any thoughts or questions, or can everyone hear okay? Okay, so we'll start off with talking about celiac disease. And celiac disease is a very interesting disease in that it affects the small bowel, and it is essentially a reaction of the body's immune system against wheat protein, and it results in eroding of the small bowel and the lining of the small intestine. And what that essentially results in is our body, the vast majority of nutrient absorption takes place not in the stomach, but in the small intestine. And so when the lining of our small intestine is eroded, or in our terms we use the word atrophic, or sort of weak, then we have a condition called malabsorption, where we can't absorb nutrients appropriately. And that's exactly what we see in celiac disease. So the body's immune system, and we'll see some pictures here in a little bit that kind of paint that picture a little more colorfully. But essentially, it's patients who have an autoimmune response. Their immune system attacks the lining of their small intestine. The symptoms, as you can see, are varied and can be anything from completely no symptoms at all, and patients walking around not really knowing they have celiac disease and having perfect health, all the way to very sick, losing weight, having chronic diarrhea, having iron deficiency, and a host of other symptoms that you can see listed here. So for the GI doc, it can be a little challenging to diagnose these patients because it has such a variety of presentations. One presentation actually, which is kind of interesting medically, is this dermatitis, what's called dermatitis herpetiformis. It's a rash of the skin that can be a little itchy and very irritating, and so sometimes celiac disease is actually diagnosed by dermatologists. When patients go see the dermatologist and say, "Doc, I got this rash on my leg. It comes and goes. Sometimes it's worse. Sometimes it's better. I've used creams. Nothing makes it go away. What do you think it is?" And they take one look at it. It has a very characteristic appearance. And they say, "Oh, you have celiac disease." So it's actually a disease of the gut, which manifests as a skin rash. So,
would that look like, what's the disease that, psoriasis? Would that look like a psoriasis rash or something?
So the question is, would it look like a psoriasis rash? So psoriasis actually has a very characteristic appearance and location. Particularly, psoriasis is found on the extensor surfaces of our body, our elbows, knees, our bottom, and has sort of a silvery plaque-like appearance. So it actually has a different look. So the short answer is to the trained dermatological eye, it looks quite different. Yeah, it looks quite different. So, so I chose to talk about celiac disease this evening because the treatment of celiac disease is a gluten-free diet. Before we get to that, we'll talk just briefly about how we diagnose it as gastroenterology doctors. There are some blood tests that we can use to diagnose celiac disease, but the gold standard for diagnosis, the foolproof way to diagnose this, is to take this instrument you see on the right, which is what we call a gastroscope, and advance it into the small intestine, take a little portion of the small intestine tissue and send it to the pathologist. They look at it under the microscope and they confirm, sure enough, this is celiac disease. So the diagnosis is made, the gold standard is just by taking tissue from the small intestine. And we also, when we do diagnose a patient with celiac disease, we go ahead and send a panel of tests for various vitamin deficiencies, iron and folate, vitamin D, calcium, etc., because these patients, as I mentioned before, they don't absorb nutrients normally, and so they often have a host of vitamin deficiencies that go along with their celiac disease. But as we've probably all heard, if we read the newspaper or watch the nightly news, the treatment of celiac disease is a gluten-free diet. And gluten-free diet is kind of one of these fad diets right now. It's gaining a lot of popularity, some of which is warranted, some of which is appropriate. And at least in my opinion, I think a lot of people are trying a gluten-free diet without a lot of medical evidence to support that. Maybe they don't need to do the gluten-free diet, but they're trying it on their own. So I just wanted to talk a little bit about what true celiac disease is versus other reasons to follow a gluten-free diet. This is a picture I wanted to include. I don't want to get into the weeds too much of the microscopic characteristics of this disease, but the picture on the right is a microscopic view of the lining of the small intestine in someone with celiac disease. And this inset picture is what it would look like under an electron microscope. And it kind of looks like the surface of the moon. It's very smooth, couple of pock marks, but it just looks kind of smooth. Compare and contrast that with the picture on the left. Let me see if I can get the cursor. Can you guys see that arrow? This is what normal small bowel histology should look like. It should look like a ton of little microscopic finger-like projections that point inward into the open part of the small bowel. And those are called villi, V-I-L-L-I. And we have a gazillion villi in our small bowel. And that's a good thing because that's where nutrient absorption takes place. Well, unfortunately, patients with celiac disease have an eroding of that villi. And so their lining of their small bowel looks real smooth, like the surface of the moon. And they don't, because of that, they don't absorb nutrients very well. So essentially, when we take those samples through the scope of the small intestine and we send it to pathology, this is what they're looking at. It's these kinds of characteristic changes that they're looking for. And so the treatment is, as I mentioned, a gluten-free diet. Has anyone attempted in the audience a gluten-free diet? Since 2008. Do you have celiac disease? Excellent. We have a patient with celiac disease in the audience, so you can tell us more about this than I could. Just a yes or no quick, is it easy or is it difficult to follow a strictly gluten-free diet?
No, it's easier at first. When my doctor told me, I was like, what's gluten?
Yeah.
But it's not really that hard once you know what you're doing.
It's not really that hard. but when you're first getting started, it feels like gluten's in everything, right? Yeah. And that's the problem. A gluten-free diet can be very difficult to adhere to. That is a strict gluten-free diet because the list on the left is, these are wheat-containing foods. So wheat, rye, barley, malt vinegars. Very difficult to, all the flours, all the breads, the pastas, all of this food that we, carb-loving folks like myself, all of that contains wheat. So it's very difficult actually to get in a mindset of avoiding these types of foods. So the challenge from the GI doctor's standpoint is to educate our celiac patients as to what they can eat and what they should avoid eating. And what I didn't mention here on the slides is that folks with celiac disease, such as yourself, if they don't follow a gluten-free diet strictly, not only will they continue to have a destruction of the lining of their small intestine, but they'll actually be at risk for developing certain cancers which they wouldn't be at risk for if they were to follow the gluten-free diet. And one of those cancers is called small bowel lymphoma. So it's not just for the GI doc, it's important to impress upon patients with celiac disease. It's not that it'll make you feel better, but it's actually going to protect you from possibly developing cancer of the small bowel down the road. So, and I know you're very well familiar with this at this point. So the category of foods on the right are foods that are gluten-free, and you can see, French fries are fine, potatoes are fine, rice and soy, and wines using distilled alcohol is okay. The beer and barley loving folks out there would have to, if they were diagnosed with celiac, would actually have to avoid beer. But the list looks kind of long, but I'm not sure how many folks are big time in the eating millet, or quinoa. But these foods are a little more esoteric. They're harder to find on the stores of most grocery, But the good news about true celiac disease is that grocery stores these days have actually really expanded their gluten-free options. So there's now, in most grocery stores like Food City and others, there's kind of the gluten-free section, and you can go and you can pick up your gluten-free crackers and the gluten-free pastas and the breads and such. So 10, 15, 20 years ago, it would have been very difficult to find that. But the awareness of the disease has really grown actually in the last 10 years. So it's, and I'm sure you found that to be the case.
Within the last couple of years.
The last couple of years. Has anyone dabbled with a gluten-free diet who does not have celiac disease? Anyone thought, hey, maybe I should cut out gluten in my diet? We see this. There's I forget his name. There are various famous people and professional athletes who will say, yeah, I'm on a gluten-free diet and I think it's helped my tennis game. There's a Russian tennis player. Anyone know his name? I forget this guy. Anyway, he swears by a gluten-free diet, and he's like one of the top 3 tennis players in the world.
Djokovic?
Yes, thank you, yes. How do you say his name? Djokovic, okay, yeah, this guy. He follows a gluten-free diet. Now, he doesn't have celiac disease, so there's no medical reason to follow a gluten-free diet for him, but it makes him feel better, so why not? There is one condition called non-celiac gluten sensitivity, and it's a very recently described disease in the medical literature where we do all the testing for celiac. The patients have all the symptoms of celiac disease. They've got the bloating, maybe some diarrhea. They just generally don't feel well when they eat wheat-containing products. And we test them for celiac disease extensively and everything's normal. And yet they go on a gluten-free diet and they feel better. And so we label these particular patients, and this guy may be one of them, I don't know, I'm not his doctor, but we label these particular patients as non-celiac gluten sensitivity, and we tell them, yeah, you probably should avoid gluten in your diet because it makes you feel better.
He sure does play good tennis.
And he's got a heck of a tennis game and a great serve.
Maybe it does help.
Yeah, who knows? Who knows? He knows. He's the best judge of his own health for sure. So that's all I have on celiac. Does anyone have any questions? Do you have any questions or?
What is the cause?
The cause is, we don't exactly know the cause. So what we do know about what causes celiac is that it's an autoimmune phenomenon, meaning the body's own immune system detects, it's an autoimmune phenomenon against wheat gluten. So when a patient with celiac disease eats gluten, which is in wheat, the immune system detects that as a foreign substance and it attacks that. And in so doing, it also attacks the lining of the small intestine. So we know that it has an autoimmune component. We also know that patients with other autoimmune diseases, such as autoimmune thyroiditis, type 1 diabetes, have a far increased risk of getting celiac disease. So where there's one autoimmune disease, there are often other autoimmune diseases. So that being said, it does affect men and women in equal proportion. Often, autoimmune diseases are more common in women, and we don't know why that is. But with celiac disease, it's actually equally prevalent in men and women.
Well, you keep saying just wheat proteins, but it's the proteins in rye and barley too.
Absolutely, yeah. Going back to that, it's gluten. So gluten is found in wheat, but it's also in rye and barley. Yeah, absolutely. Yeah. Mm-hmm.
Well, I don't see any sweets up there, and I asked her if she could eat sweets, and she says some.
It depends what else is in them.
Yeah.
Like Twizzlers are made with wheat flour, so I can't have those.
Yeah. It's a great example. I mean, it's one of those things where gluten is just so prevalent. I had a friend in med school who had bad celiac disease, and if she had gluten-free bread, which was put in a toaster, which previously had regular wheat bread, she would have a flare and would get bloating and abdominal pain. I mean, very sensitive. Yeah, so it's one. So, yeah, bad. So people with real bad celiac disease actually have to get separate, you know, yeah, plates, forks. Yeah, I mean, it's a true autoimmune disease where they react every time they're exposed to the gluten or that antigen. Any other questions? Okay. I wanted to talk about irritable bowel syndrome because it's probably the most common GI disease that we see in the clinic on a day-to-day basis. It affects up to as many as 1 in 5 Americans or 1 in 5 people in Western cultures today. And it is interesting, and I didn't know this until I was preparing this talk, it's the second most common reason for work absence, number 1 being the common cold. That's pretty impressive if you think about it. I mean, just the sheer financial burden on how many people miss work and missed productivity due to the common cold. Well, number 2 behind that is symptoms of irritable bowel syndrome. So what are the symptoms of IBS? They are predominantly abdominal discomfort associated with change in bowel habits. And those change in bowel habits can either be constipation or diarrhea. And I like to use the analogy of, you know, a common presentation would be like a 19-year-old kid goes off to college, is doing okay and maybe a little more of a type A personality. November rolls around and exams are coming up in the first week of December, and they're under the gun to study for these tests, and they get a little bit, as stress mounts, they get a little bit of abdominal discomfort and a little bit of diarrhea. That's classic irritable bowel syndrome. It's a disease which affects, as I mentioned, up to 20% of the population of Americans today, and the causes are many, and they're not exactly clear to us at this time. We have several theories as to what causes irritable bowel. We know for sure that stress exacerbates it, makes it worse. And we know that most patients who have been studied with irritable bowel have been found to have what's called sensitive gut. So the nerves that activate their intestines are a little more active and a little more quick triggered than the intestines of those without irritable bowel. So that what we call in parentheses up here, visceral hyperalgesia, means that they're just a little more sensitive, or in some cases far more sensitive than the guts of those who do not have irritable bowel. So the symptoms, as I mentioned, crampy, variable abdominal pain, and either diarrhea or more of a constipation predominant type of symptomatology. And the diagnosis is often one of exclusion. This is not a disease that will in any way impact someone's long-term mortality. If they're diagnosed with IBS, they're not going to die 10 years sooner than someone without it. But it does cause them discomfort from day to day and week to week, and it impacts their lifestyle. So it's often a disease that we as GI doctors will diagnose once we've ruled out other causes of abdominal pain. If we get a CAT scan of the belly, and that's normal. If we do a colonoscopy, and that's normal. If we do some blood work, everything looks normal. They have these symptoms. We say this is irritable bowel. So it's what we call a diagnosis of exclusion, meaning we've ruled out all the nasty stuff, all the dangerous stuff, and then it's irritable bowel syndrome. The treatment of irritable bowel is we generally take a kind of a 3-pronged approach to the treatment of irritable bowel. The first prong would be dietary modification. Often we recommend a 2-week trial of a lactose-free diet, because lots of times lactose intolerance can look a lot like irritable bowel syndrome symptoms. So we say, hey, cut out the milk, the yogurt, the ice cream, as hard as that may be, and it is hard, I love ice cream, but we say try going off of any lactose-containing foods for 2 weeks and see if you feel better. If you feel better, it's likely lactose intolerance and not true irritable bowel syndrome, and then we have our diagnosis. If the patient still doesn't feel better, we recommend avoiding foods with gas-forming potential. And I think at this point we probably all know what these kinds of foods are, but beans, cabbage, broccoli, these sorts of vegetables. So we do this sort of dietary approach. And then we also recommend to increase dietary fiber, and that can be done through an over-the-counter fiber supplement like Metamucil, psyllium powder, something like that, or a daily cereal or a whole grain bread or something like that. So that would be the first prong. The second prong would be the medications that we typically prescribe to patients who, after trying a trial of diet modification, they're still having symptoms. Doc, I'm not better. I've cut out milk and yogurt. That didn't help. I avoided all the foods that you told me to avoid, and I increased my fiber, and I'm still having a lot of symptoms. In those cases, we generally prescribe the medicine called Bentyl, B-E-N-T-Y-L, the first medication mentioned there. And it's highly effective. It actually is it's what we call an antispasmodic, so it relaxes some of the contractions of the small bowel, and often patients do very well with that. The third prong, as you can see, there are a number of other medications which, depending on the severity of symptoms, we may sometimes try certain patients on. The third prong of our treatment would be a real conscientious look at the patient's stress in their life, and this may be as simple as just kind of an inward reflection on stress and trying to eliminate stressors in life, all the way up to as significant as sending the patient to a psychiatrist for evaluation of anxiety or depression or anxiety disorder. So we really take this quite seriously. This is a disease that can affect lifestyles profoundly. But the good news is that it's not life-threatening, and it doesn't have any long-term effect on life expectancy. But it's very common, and that's why I wanted to mention it. Any thoughts or questions? Okay, we'll move on to treatment of talk about diverticulosis. This is very common as well, and this is one reason why I wanted to bring it up. Normally, the colon would have more of an appearance across, like what we see at the top here. The colon should have these nice healthy folds. These are called haustral folds. And it kind of twists and turns and what have you. But in some patients, particularly older patients, they have what's called these pockets or diverticuli. And these are demonstrated very nicely right here. If I can find my little pointer. Yeah, here we go. Okay, so these are outpouchings that are typically caused by chronic constipation and weakness in the wall of the colon itself. They're very common. I mean, perhaps as many as half the patients over the age of 60 have the presence of diverticuli in their colon. And most patients who have this do fine. They don't even know they have them. But there are some fairly serious consequences, potential adverse consequences of having them. And they are namely inflammation of the diverticuli, which is called diverticulitis, bleeding of the divertic, which is diverticular bleed, and can be a third thing at the bottom, painful diverticular disease. Has anyone here in the audience known anyone who's ever been diagnosed with diverticulitis or had complications? Yeah, it's a very common condition. We see it quite often in the hospital and in the clinic. The treatment recommended dietary change is to follow a high-fiber diet. There has been for years this recommendation of avoiding nuts and seeds and corn, and I'm happy to report to you today that that's no longer recommended. That was a recommendation that was put forth years and years ago and was just repeated and repeated, just kind of medical convention, you can't eat popcorn anymore, and some patients really get bummed out about that,
Even strawberries.
Yeah, right,
I have a
strawberries.
friend who says, we can't eat strawberries.
Yeah, exactly. Strawberry, anything with a little tiny seed. Because the thinking was those seeds would go into the pocket and set up an infection or maybe cause a perforation or something. But again, if you don't remember anything from today's talk, eat what you want to eat if you have diverticulosis. Because the presence of corn and nuts and seeds in the diet has not been shown to increase the risk of diverticulitis at all whatsoever. That's been looked at in a very large study in the West Coast that was published a number of years ago. But still the common knowledge persists, and people say, oh yeah, you can't, strawberries. I love strawberries, I'm not going to have anybody tell me I can't eat strawberries.
Right.
So that's that's the good news. Diverticulitis can be quite serious. It occurs in up to 1 in 4 patients who have the presence of these pockets, who have diverticulosis. And if it's the symptoms of diverticulitis, that suffix itis, itis just means inflammation. So the symptoms of diverticulitis include fever, abdominal pain, often on the left lower part of the abdomen, and patients generally are very nauseated and they feel terrible. If it's a fairly mild case of diverticulitis, we can often treat this in the clinic without having to send the patients to the hospital. We can give them a 10-day or 2-week course of antibiotics to take at home, and they get better. Some patients can develop unfortunate consequences, and actually those pockets, as you might imagine, the walls of those pockets are fairly thin, and they're at risk to rupture. And that can be fairly serious and require an abdominal surgery to repair. So those patients we put in the hospital, and we keep them fasting. We give them IV antibiotics, and we have surgery, see them, and consider them for partial colectomy or removal of part of the colon. So that can be actually a fairly serious consequence of having diverticulosis. However, let me again reiterate: there's no increased risk with seeds, nuts, and corn. So if that's the one takeaway point today.
Well, I don't have it. No, but our friend does. We have a friend who.
Yeah, strawberries all day long. And finally, at the bottom, diverticular bleeding is a very, very common cause of lower GI hemorrhage or rectal bleeding in patients who have diverticulosis. And it can be, most patients who bleed from their diverticuli stop spontaneously. They bleed maybe for a matter of a few hours, and then they stop. Some patients, and these bleeds can be very significant, will continue to bleed, and they only stop with either surgery or an intravascular intervention called embolization. And but that, just to be aware of a third kind of category of diverticulosis.
How would you know if you had diverticular bleeding? Would it be through the stool or what?
Mm-hmm.
That's what
It'd be blood coming right out of the rectum.
Oh, okay. Because I've never heard of that.
Bright red blood. Typically, the rule of thumb that we use in the hospital is that if blood that originates in the upper GI tract, meaning the stomach or the first part of the small intestine or even the esophagus, by the time it passes through the 20-some-odd feet of small bowel and through the 3 or 4 feet of colon and passes out, it looks black because it's processed and it's hemolyzed by bacteria. So red blood that bleeds from the top of our GI tract, from the stomach or first part of the small intestine, comes out looking black. Blood that originates from the colon doesn't have time to break down and be hemolyzed, so it comes out looking like blood. So it comes out red. So rectal bleeding, it's probably one of the most, diverticular bleeding is probably one of the most common causes of rectal bleeding. There are a number, there's 10 or 15 causes, but that's one of the most common. And again, in most patients, I would say probably 3 out of 4 times, or maybe even 8 or 9 out of 10 times, that bleeding stops by itself. So we just we put them in the hospital, we watch them very carefully, we give them medicines, and we monitor their blood counts, make sure they're not becoming too anemic, and they stop.